Okay. Hi everyone, I'm Shilpa. I'm a PhD student from the University of Birmingham, UK. So my research is on the microscopic changes in the multifidus muscle in people with low back pain associated with lumbar disc herniation. To begin with, as we all know, low back pain is one of the most common musculoskeletal disorders, and nearly 80% of the people experience this pain at least once in their lifetime. So it's highly prevalent. And lumbar disc herniation is one of the most common degenerative disorders, which causes low back pain and lower limb pain, which is commonly known as sciatica, due to the nerve compression. And the muscle that I'm researching is the multifidus muscle, which is an intrinsic muscle of the back, and it's also called the spinal extensor muscle. This is the most commonly examined muscle due to its unique unisegmental innervation. So if you can follow the picture, how the disc herniation causes the nerve compression, and this is the multifidus muscle that will be affected. These are short segment muscles, so they'll have a single segment innervation, single spinal root innervation. So any nerve compression or injury directly affects the muscle. To give you a bit of background on why this research was done, previously multiple studies have examined this muscle in disc herniation patients, but they have compared the muscle at the level of disc herniation with the contralateral multifidus muscle, or they have compared the affected muscle with the contralateral muscle. Or they have compared the multifidus at the level of disc herniation or the affected muscle with the cadaveric samples. So because of this varied methodology, their conclusions also varied on the muscle fiber size, structure, composition, area, and it also varied based on the pain duration and severity. So based on our previous studies, we hypothesized that there will be atrophy of muscle fibers, both type 1 and type 2 fibers in our study. So the main objectives of this study was to compare the muscle fiber morphology, including the fiber cross-section area, fiber perimeter, diameter, and percentage fiber type composition in the affected multifidus with the adjacent muscle segments on the ipsilateral side, that same side, and the contralateral side in people with disc herniation. And our second objective was to examine the correlations between features of multifidus microscopy with the clinical features of low back pain. So if you look at this image, you can see this is a disc herniation at L4, L5 disc level. This is just a schematic representation. So if there is a disc herniation here, the spinal nerve crossing the disc will be compressed. So the nerve which exits the same intervertebral foramen level will remain unaffected. So the muscle innervated at that level remains unaffected. So the muscle segment below the disc herniation is actually affected by the nerve compression. So our aim of the study was to compare the segment 2 with the segment 1 and 3. So that is the adjacent segments on the same side and one segment on the contralateral side. So 1, 3, and 4 were considered the unaffected muscle segment, and 2 is considered the 2 is the affected multifidus muscle. So for this, we collected data from 30 NHS patients who were on the elective surgical list for the microdiscectomy surgeries from the Royal Orthopaedic Hospital here at Birmingham. Screening was done and patients were selected based on the eligibility criteria. Written informed consents were obtained and patient details were anonymized. Patient-reported outcome measures were also gathered, which included pain intensity scale and the disability index. For tissue sampling, 4 muscle biopsy samples were taken from each participant. The tissue was fixed. It was embedded in OCT, which was frozen in isopentane, pre-cooled by liquid nitrogen, and these samples were stored at -80 degrees centigrade. Once a number of samples were collected, they were all transported to the university lab in dry ice under the material transfer agreement. For data extraction, each of these samples were sectioned to thin sections of 7 micrometer thickness using a cryostat at -25 degrees. And these sections were then stained. So immunohistochemistry was performed using primary and secondary antibodies for MHC class 1, MCH class 1, class 2A and class 2X and laminin. These sections were observed under the microscope, fluorescent microscopy under 20 times magnification. Several images were taken and these images were measured using Fiji ImageJ software. So the data collected was analyzed using ANOVA and Pearson's correlations coefficient. For outcome measures, we primarily had 4 outcome measures, that is to measure fiber cross-section area, fiber perimeter, fiber diameter, and percentage fiber type composition. For secondary outcome measures, we had relative cross-section area, pathological fibers, and we examined the correlations with clinical features. So if you look at this image, this is an image of an unaffected multifidus or a healthy multifidus segment observed under the fluorescent microscopy. So the image A here, this is the image this is a cross-section image of the multifidus under all the channels, that is blue, green, and red channel. So in image B here, you can see this is the blue channel. So the fibers appearing in blue are the type 1 fibers. And in image C, you can see green fibers. These are the type 2A fibers. And in image D, this is the red channel. And we are supposed to see type 2X fibers, which are the fast glycolytic fibers. And obviously, we do not see any fiber in this figure. That's because they were hardly present in many of the samples. So moving on to results, we had a total of 30 participants, 11 men and 19 women. Pain intensity, lower limb pain, and the perceived disability as well. So on analyzing the results, on measuring the fiber cross-section area, we found no significant difference in both type 1 and type 2A fibers when the affected muscle was compared with the unaffected samples from the various sites. But we found a significant difference between the type 1 and type 2A fibers. And on post-hoc analysis, this showed that the type 1 fiber cross-section area was greater than type 2A fiber cross-section area, regardless of where the multifidus was located. Similarly, for fiber perimeter, there was no significant difference for both type 1 and type 2A fibers when compared with at different sites, but there was significant difference with type 1 fiber perimeter greater than type 2A fiber perimeter, again irrespective of the multifidus location. Similarly, for narrow diameter also, there was no significant difference for both type of fibers when measured at different sites. And on post-hoc analysis, type 1 fiber diameters were greater than the type 2 fiber diameters at all the locations. Coming to fiber type composition, there was no significant difference again at different sites, but there was statistically significant difference, that is type 1 fibers were more, the percentage of type 1 fibers were more compared to type 2A fibers, again regardless of the multifidus location. So we also mentioned that there are other type of fibers. So type 2X fibers, as I mentioned, was not seen in the red channel, but it did not mean that they were totally absent. They were present, but they were not present in all the samples. And when they were present, they were in very small numbers. And that's why no statistical analysis could be performed on them. And we also came across multiple intermediate fibers or the hybrid fibers like type 1, type 2A fibers and type 2AX fibers. So when we look at this table for fiber type composition, we found there is a small tendency for higher percentage of type 2X and type 2AX fibers at site 2, that is the affected muscle site, and at site 1 compared to the other sites. When we measured the relative cross-section area also, there was a small tendency for higher cross-section area for type 2AX and type 2X fibers at the affected site compared to any other site. So these are all the numerical differences, and no statistical analysis could be performed because of inconsistency in their appearance. So we also observed some pathological fibers when we were trying to quantify the primary outcomes. So some of the pathologies that we came across were, you can see in these images, so moth-eaten appearance of the fibers. So it looks like eaten away by moth. And you can also see some core targetoid fibers, the fibers appearing like the target region. And there is some group atrophy of the fibers you can see here. So these are all the signs of nerve injury or nerve compression. And you can see in this image lobulated appearance of fibers and some split fibers here, as if the fiber is trying to split away into two. And again, more here, moth-eaten appearance of the fibers and lobulation, and some group atrophy and fiber type grouping. And we also saw some small angulated fibers, as you can see in number of images. So these are all the pathological signs that we came across in multiple segments, including the samples that we thought were normal. But when these pathological fibers were quantified, we found a significant difference between the sites, and this significance was greater for the affected sample. So the affected multifidus site had greater moth-eaten fibers and group atrophy of fibers, indicating severe axonal injury and the effect of the nerve compression on the muscle fiber. Finally, moving on to our second objective, and the final objective, which was examining the correlations with clinical features. So when we examined the clinical features here, we mean the pain intensity and the perceived disability score. So we found a weak but a significant negative correlations between the type 1 fiber cross-section area and the pain intensity, both average pain intensity and the ODI index. This is the disability score. So there was a significant negative correlation. Similarly, for type 1 fiber diameter and perimeter, we found negative correlations with the disability index. However, there was no correlations noted for type 2A fiber parameters with any of these features like pain intensity or disability. So this brings us to some important discussion points. So when we observed the effects, when we compared the affected and unaffected multifidus, there was no significant difference, and these results are comparable with some of the recent systematic review. When we compared the type 1 and type 2A fibers, type 1 fiber parameters were greater than type 2A fiber parameters, which also supports the well-known role of the muscle itself, which is postural stability. And we noted type 2X fibers and hybrid fibers in greater numbers in the affected sample compared to any other sites. So this indicates a possible glycolytic shift with gradual fiber type conversions, possibly due to pain, muscle disuse, and nerve injury. And we found significant pathological fibers in the affected sample, which clarifies the axonal injury at the site and also indicates the muscle fiber changes due to the nerve injury and also possibly due to inactivity. And finally, for clinical correlations, there was no atrophy or decrease in type 2A fibers, again indicating a tendency towards the glycolytic shift, possibly due to altered patterns of muscle activation in pain. So to conclude, we can say that there was no differences in the microscopic features of the affected lumbar multifidus when compared with the adjacent site both ipsilaterally and contralaterally. The fiber type composition and muscle fiber parameters were greater in type 1 fibers compared to type 2 fibers, regardless of the location and irrespective of the nerve compression. However, there were more pathological fibers in the affected muscle segment. And finally, the higher the pain intensity and disability was associated with smaller type 1 fiber size. So what does this research indicate? So what does this research directly imply to clinical sciences? So we can say that having a sound knowledge on the quality and quantity of the structural damage in the muscle due to nerve compression will aid the healthcare professionals, both doctors and the physiotherapists, in effective management of the low back pain patients. It also dictates or guides the prognosis. So the greater the nerve compression or injury and longer it is left, it can lead to irreversible damage due to increase in pathology in the muscle segment. The earlier it is treated, the better chances of recovery and better quality of life as well. So these are some of my references. Thank you very much. Any questions? I'm happy to take.